Welcome, everyone. We'll get started in just a moment. Welcome to today's webinar. We'll be starting in just a moment. We'll be starting in just a moment. Hi, everyone. We'll be starting in just a moment. Hi, everyone. My name is Heather Zemo. I'm the Education Director at IAHSS. Welcome to today's webinar on healthcare incident categories and data analysis. We will allow some time at the end of this presentation for questions. You can use the Q&A option at the bottom of the screen to submit your questions. We will also be allowing you the option to raise your hand at the end of the presentation. At that time, you will be asked to unmute yourself, and then you can ask a question verbally if you'd like. This webinar is being recorded and it will be available to everyone here. I'd like to welcome our speakers for today, Tony York and Dave Brown. Dave?
Thank you, Heather. So on behalf of the IAHSS Council on Guidelines, I'd like to welcome everybody to today's webinar. Very interesting topic for today. We're going to be discussing the incident categories and data analysis guideline, along with the glossary of terms and the framework that's used to support this initiative. So we'll do some brief introductions in a minute, but just to give you an idea of this guideline, this is a very significant undertaking by the Guidelines Council. It took us around 2 years actually to put this together, and we normally would have produced some other guidelines at this time, but it's such an important topic. Data drives everything these days, and we're going to get into that a little bit more and talk about how you can use this framework and guideline and glossary of terms to help improve your security program. So before I go any further, I'd like to do some introduction of us. I'll turn it over to Tony, who can introduce himself, and then I'll take it back.
Thanks, Dave. Hello, everyone. I'm Tony York. I'm an Executive Vice President of Healthcare Security for the Paladin Security Group, a long-term member of the Guidelines Council. I think I joined the council back in 2009. Some of you may know me as one of the co-authors of the last 2 editions of Hospital and Healthcare Security. Dave?
Thank you, Tony. So I am Dave Brown, and I am, you could consider me the I in the International Association in regards to the Guidelines Council. I am, in fact, the chair of the Guidelines Council and proud to be an international member. So my particular program, I'm based in Vancouver, British Columbia, and we run a large program, one of the larger programs in Canada, actually. We manage approximately 26 hospitals in a publicly funded healthcare system, which of course is different than many of the programs in the United States. We service about 2.8 million residents, and we have about 60,000 staff across our organizations. We take care of corporate and site security services. We take care of electronic security systems. We do photo ID access control, parking administration. We manage the heliports for our organization. We have a threat management program. We have quite a large group of people who many of you are familiar with. So I'm proud to be here today representing the council. So go to my next slide here. So I'll give you a brief history of the Guidelines Council because I think it's important. The council itself was established by Russell Colling, was the original Special Task Force chair. I did not get a chance to meet Mr. Colling, unfortunately, but I've traveled in his footsteps, and it's really quite some footsteps to follow in. Our group from the Guidelines Council are literally scattered all over North America, from literally one end of the country to the other and north of the border. So the current contingent of members who I'm very proud to be representing today are myself as chair, Kat Kemper, who is the vice chair, Alan Butler, Anjanette Hebert, David LaRose, Mike Lauer, Mark Reed, Tom Smith, Dean Subkowiak, Brian Warren, and of course, Tony York. Our staff liaison is Heather, and our board liaison is, of course, Paul Sarnice, who most of you probably know. So this council works very hard on a daily, monthly, annual basis to produce a lot of work. And to give you an idea of some of this, just before we get into too many of the details of the actual guideline we're discussing today, I just wanted to remind folks that the online resources for the IAHSS are the best place for you to find all this information. Things are often evolving within the Guidelines Council and the items that we produce. So for example, you might not realize that we recently put together all of our violence related items into a workplace violence prevention bundle. And so that's just one example of the resources you can obtain from the association, because rather than looking, you can always get your information, download these individual guidelines for no charge from the website, but you can also buy the publications that have things bundled together. We have industry guidelines, and we have, of course, design guidelines, both of which are kind of separate disciplines in the work that we do. And we also create things like the bundled, workplace violence prevention bundle. So there's all kinds of resources there that you may not even realize. Even for those the more experienced members, you're going to find a lot of resources there that you might not even realize. So let's get to a little bit more detail here. So what's the intent of the Guidelines Council? So our council produces guidelines, not standards. Having standards is different. The guidelines are basically intended to reinforce the need for healthcare specific, risk-based, collaborative planning and work by multidisciplinary teams. It's recognized that the application of these guidelines will vary from healthcare facility to facility, and it depends on many factors. And these types of variables go into every guideline that we create. We need to know about the healthcare location. We need to know about the services offered at your location, the historical and forecasted crime in your areas, internal crime and incidental trends, and other foreseeable risks. So our goal, our mandate really is to create guidelines which will apply to even a small rural hospital all the way up to an urban hospital. So that's always important for you to keep that in mind when looking at our guidelines, because they're intended to be a useful tool for everybody who is in the industry, whether it be a small rural hospital or whether it be a large hospital. We take great care to try and facilitate a guideline that will apply to all different groups. It's very challenging at times. We have some very significant debates on the work that we produce. Sometimes we spend many a days talking about even one word or one sentence, but it's always in good faith. And at the end of the day, we always seem to come out with something that's usable for the group. So that's something to consider. So I'm now going to move into the business of the actual guideline itself. So the actual guideline itself, right here, which is it's 010502, which is the guideline that we're going to talk about today. It's important. So what I'm going to do is I'm going to tell you a little bit about the guideline itself, and then I'm going to turn it over to Tony, who's going to talk about the framework and the glossary, because it's important for you to recognize that you need you should really look at this guideline in the context of these other documents as well. Think of the guideline as being supported by the other two documents that Tony will tell us about. Because if you just read each one in isolation, you might get confused by it. So it's really important to look at it as a whole. And I think one of the most important things I can point out about this guideline is that for those of you who are familiar with the annual survey that comes out from the foundation, one of the primary drivers for us to create this guideline was the fact that our intent is this: if you were to actually follow the guideline as we have created it, you would be in very good shape to be able to respond to the annual survey from the IAHSS Foundation. Sounds easy. It's challenging because there's a lot of information in this guideline, and it's going to take some interpretation on your part, because it's important for you to know that we don't necessarily tell you how to collect the data. We'll tell you what kind of data you should be collecting, but not necessarily how you're going to do it. So that part's a little bit tricky. And again, if you look at the framework and you look at the glossary of terms, it will probably be helpful. So let's look at the actual guideline itself. So 010502, there, as most of our guidelines, or as all of our guidelines start, we have a clear statement. And I'm just going to read the statement out loud. I'm not going to read the whole guideline out loud, but I think it's important for you to understand the statement, because a lot of effort goes into these statements when we create these guidelines. So healthcare facilities should collect security incident and activity data to monitor the environment, make data-driven decisions, and meet regulatory compliance. Collecting standardized incident and security activity data will assist healthcare facilities to benchmark nationally and internationally. Statistical data should be used to support the security program initiatives, quality, and efficacy. So it's really important for you to understand that the framework that we put together is grouped into these different categories. When you go into the actual intent, it's going to talk about why you should collect the data, how you should collect the data. It's really important for those of you who are, I guess, to overstate the obvious, data drives everything. And if you can't tell your superiors about data, you're going to be pushing a rock uphill longer than you would hope to. If you can invest your time in actually producing the data, you'll be surprised how quickly things can turn around for you by producing valuable data for your C-suite, as it may be. So, in regards to the intent of the guideline, so we have a number of different incident areas to consider. So we have basically to put them into categories. We put these into buckets so that people could probably better visualize how this data should be collected. But we basically are asking people to collect violent and aggression data, crimes against persons, any other types of crime, security assistance, which is sometimes you can have incidents and activity separated a little bit because they're not necessarily the same thing, but this will help guide you there. Any emergency responses, and as well as safety and facility management. So this is, when you read this particular guideline from start to finish, you'll realize that if you were to actually hit a home run and get everything in this guideline within your program, you would be, it would be exceptional. I don't know if anybody could really expect to do 100% of the guideline right off the bat, but it's something for you to work towards. It is a very, a lot of thought's been gone into each piece here, and it took us a very long time to vet the information through our group, to send it out for feedback to different, including different organizations. And it is, it's a very substantial piece of work that will help you create a substantial data, basically collect a lot of data for your organization. The other piece that's really important before I turn it over to Tony is the data warehouse project. So for those of you who are familiar with the data warehouse project, this will support that. For those of you who are not aware, it is basically the data warehouse project is a project that the IAHSS has underway, designed to be a data exchange or a data sharing service, if you will. It's not going to have any personal information or any organizational information, but the intent is to have data available to folks within the IAHSS to see how your facility might compare to other facilities without getting too much proprietary information away to for example, where you have competition in some healthcare markets. The intent is to provide accurate information for you to make decision making, but not necessarily supply proprietary information that might hurt an organization. So all of these things will help you. It'll help the organization, and you'd be surprised what kind of success you can have by having a really good data, even if it's just a small amount of data that's done accurately and well. You can make that work a long ways. I will turn it over to Tony now, who can basically help put this further into context, because he'll explain to you how the The glossary of terms works in conjunction with the guideline as well as the framework, which is kind of the overarching structure that you can work towards. Tony?
Absolutely, Dave. And I'll leave the guideline up for just a moment while we're thinking about, as we look at what is it that we've always historically been collecting. And when I say we all have always been collecting, it actually has a lot of variability when we think about program to program throughout North America and frankly across the globe. And what are we thinking is, what are we capturing? How are we organizing the security incident activity? So much of the guideline was trying to put framework around how that happens. And then we wanted to realize that there are a lot of similarities in the fact that we are capturing data, but there's a lot of variabilities for what we call an incident, what we might refer to as a security event. And then there's also this big issue of how do we define it? So it's historically made healthcare security very challenging to actually have comparables between facility to facility. And that's one of the things that we really started out on this journey when we went to the conversation that says, how are we able to overcome that? At the heart of this was at the early phases of the data warehouse project. And we recognized how important it was to move from the art of how decisions were being made inside of healthcare security and the funding and the resources that are being allocated, all the way to more of a science approach. All of us in our healthcare organizations, I think, would recognize that healthcare has historically been much more of an evidence-based approach to how decisions are getting made. How many times have you been asked that question? What about other facilities? How do we know that mitigation is actually effective? What do other facilities look like? What are they doing? How much staff do they have? What kind of FTE ratios do they have to square footage? What kind of FTE ratios do they have to the type of emergency department environment that they're carrying? All of these were drivers to helping us understand. So that's why, as a council, we actually embarked on a strategic journey, a journey that was really more, how do we create more standardization? How do we create more consistency in our approach to the collection and the categorization of security incident data that we're really grabbing in healthcare? So what you see on the screen is a snapshot of frankly, what you can download online at IAHSS.org. I'm going to click into this particular document here for a second, and let's look at the framework for a moment, because this new framework is designed with a very specific intent. How do we capture security incident and select event categories in a consistent approach for every healthcare facility in North America? Now, mind you, as we were building this out, it was a wonderful multidisciplinary team. In addition to the folks that are currently on the council and guidelines, I had some wonderful colleagues that jumped into the fray with us. Folks, Lisa Terry, Brian Hamilton, who was our board liaison at the time, and provided just tremendous insight to what we're trying to accomplish. But this framework basically wanted to provide recommendations for how are we really grouping our buckets, as Dave alluded to earlier, and trying to put framework to that type of thinking. So there is the idea of the crime that happens in healthcare, but not all aggressive behavior is crime. So we ended up using a bucket we refer to as violence and aggression. We also wanted to go with something that was more other criminal activity, sort of the catch can. We know we need to be thinking about crime, so we can really compare it to our communities and other things that are happening. Sometimes it helps us with understanding and really establishing how effective our programs are. Then there's the issues that are the emergent events that happen. In addition to, you'll hear me refer to incidents and events. Sometimes it's activities, security assistance that we're providing. What are we doing with the programs that we're leading and administering? And then lastly, we want to talk about safety and facility management. But in the midst of all of this, we were also taking advantage of some of the science that was going on. And Kat Kemper, who is our vice chair, really brought forward an idea that said, how can we start thinking about the typology that we know that is being promulgated in so many other ways for workplace violence types? Where were our victims and who were our perpetrators as we were thinking about it? So as you can see on the screen right now, those 5 types were something that we wanted to make certain. Were we able to collect? Were we able to produce that? But I'll just share with you that we also wanted to have something else, and that was the severity levels associated with certain injuries that might happen. Was there a classification that we could actually attach to it? So, in like most, we didn't try to recreate the will, but we tried to refine the wills that were already in process. So we took advantage of some industry resources that were outside of security, mostly in how a lot of our colleagues in the workers' compensation arena were really thinking about the injuries that were being sustained. But you can see here, we wanted to create a classification scale. So as we go through the actual framework itself, you'll see how this has demonstrated itself. So under the category of violence and aggression, let's just maybe spend some time with that. Obviously, you see these are a lot of traditional criminal acts, especially Part 1 crimes, crimes against persons would probably be the maybe a loose way to communicate that. But you can see assault as the second line down, aggravated assault, simple assault. You can see that as our subcategory. You can see underneath that, we didn't put an incident type or person in this particular issue, but I think it's important that we stop for just a moment and share. What we're trying to do with this framework is giving you a baseline for items that we all are collecting as an industry. It doesn't mean that you may not want more granular level detail in the type of information that you're collecting in your organization. So please recognize, as you start thinking about how this gets deployed in your own organization, feel free to go ahead and be additive to it. We just wanted to make certain we were collecting some of the key components that we all wanted to know about as an industry. So back to the assaulter category, you can see the typology for workplace violence. So it would be pretty straightforward to go through with this. And then the injury severity level that we just discussed. Now, what's important for this is, for those of you who are using some off-the-shelf products, we definitely took advantage of our industry representatives who gave us tremendously positive feedback about it. They helped us understand that, hey, is this something that could easily be done inside of their customizable database? And what's so nice about that is they are actually, many of them, starting to look at this and saying this could be, and probably will be, their framework for the future for how they're actually bringing the off-the-shelf healthcare security framework to the market. But it's also was very clear to us that they did not believe it would be an overwhelming challenge to make certain that we were able to have the same communication and making any kind of revisions that you would have. But if we went back into the framework itself, you can see the homicide, murders, disorderly conduct, you can see robberies. I won't read all of this to you because I think many of you have probably already, in preparation for the discussion, probably have downloaded this off the website. But you can see how we actually looked at other criminal activity. You can look at how we looked at arson, how we looked at cybercrime, realizing that not always are cybercrimes physical security incident reports generated, but oftentimes we are brought into those conversations. We wanted to make certain we were collecting those, especially with how frequent those events are happening in our world today. You could see illicit drugs and paraphernalia, whether they were found or in possession, and if we were actually having to write an incident report. Again, we're not saying right now you've got to define who all those people are. But if I'm in your shoes and I was building this out for my organization, I'm probably wanting to know that. That's not probably something we're going to be asking for as part of the data warehouse project or some of the data that the IAHSS repository is ultimately going to collect. But as you go through here, you can just see how this framework pops. And you can see something as simple as, the external emergency issues, the disaster plans, these disaster exercises that we do, the events that occur. It could be just a drill, or it could be some of the naturally occurring events. So you can see now how this third tier categorization has started happening as we think about naturally occurring events, whether we have an ice storm or a wildfire or any of the other events that could have happened. Same concept when it comes to internal emergency disasters. We're thinking about, hey, what are the hazardous material events that could occur inside of organizations? What are the human-related events that happen? The active assailant here is where it would be. The bomb threats, the civil disturbances, a labor action, or basically even a terroristic attack. But we also have the medical events that we know we are actually responding to as predominantly as an entity, whether it's an epidemic issue or mass casualty, or it might be a pandemic response that is put into place. But as we continue to go through that, you'll see that we have the technological infrastructure events that could occur, whether those are failures with our generators or our gas systems. Maybe it's a structural damage or water failure, but we're trying to collect those. Now, in such situations, you'll see that the topology and the injury severity are blank in this particular framework, because obviously those are not applicable. So those are the kinds of things we're trying to think about for the data tables that we put together, so it could be easily applied to whatever system, whether it's off the shelf or something that you've actually created for yourself, working in partnership with an IT member or somebody who's talented on your team, etc. But then we get into what we refer to as the security assist. If you've asked yourself a question, it's like, well, Tony, how did you sort of lay these things out? We basically have everything in a bucket, and then it's alphabetical in the category section from there. And we stayed in that kind of framework. So there's no prioritization other than the alphabetical approach that we took. But you can see that we're actually trying to keep information on, hey, a forensic patient, the prisoner patient for my Canadian colleagues, that is sitting out there, that we want to make certain. Did we have to perform an escort? Was there an admission staff orientation? So again, these are not always events or incidents. It could be activities, but we try to attach to the number of activities that we know are common and sometimes are being scrutinized by others that we have to maintain compliance with. So it was important that we're putting this into. All the way down to the missing person, we get into the LMAs versus patient elopements to the patient wandering.
Tony, it's if I could just interject there a little bit. So for the Canadian members of the audience, so you might be looking at some of the language or some of the vocabulary being used, and we tried to make it so that it was generic enough so you could use it both sides of the border. So of course, some of our criminal laws, of course, are a lot different north of the border than they are south of the border, and so you'll see a lot of generic type language which may not 100% fit, but you should be able to find categories that fit regardless of whether you're north of the border or south of the border. So we tried to take a truly an international approach here as best we could, keeping in mind that you can't satisfy all categories all the time, but we really tried to make it so that it was accessible from an international perspective, not just not necessarily a one country based perspective.
Great piece of insight, Dave, and I'm glad you said that, because obviously there's so much commonality between North America, but there are some very distinct differences that I think we always want to try to be sensitive to, and that always it makes writing guidelines hard sometimes, and it's good for us to recognize where we have a lot of commonalities, but there are some very distinct differences. I'll point your attention to something, though, I think is important to call out. It was probably some of the richest discussion that we had as the framework and even the glossary terms were built out, and I'll talk about in a moment. But when we start talking about the patient assist, you'll notice that there's the patient escort on campus, off campus, pretty straightforward to lift. Patient restraint, whether it was an assist or a direct application of the restraint. But the patient standby, I'm going to compare this to some other words, but you'll notice there's a term, and we'll get into this in the glossary, but it's not free to leave. And I mention this to you all because what we've come to realize is there's a patient standby and there's the security watch. And what we wanted to make certain was we tried to give our organizations and our industry some clarity as it related to what are the differences. And so many programs that so many of us have had a chance to be and walk in around, we find that the security watch or patient assist is a generic term used across the spectrum, but it's probably the single largest activity that we're all engaged with that consumes the security resources more than almost anything else that we would chat about. Maybe not have the same level of intensity, sometimes they do, obviously, but what we wanted to realize is the security watch is someone is there, They're not on a hold. They're in California, they're not on a 5150 or a Baker Act in Florida or wherever you may refer to that in your specific geography. But we also realize that that's where the mere presence of the officer may be called to stand by and just do that versus the security watch. So you'll just notice that those terms are applied here, and we're trying to move the industry a little differently on that front. Now, I won't bore you with all the rest of the specific issues, but you're probably asking, well, where's our catch cans at? Where are the things that we have? So you can see a lot as it relates to the alarm systems. You can see equipment failure issues that are loaded. You can see that we have even things that we're often accountable for in the security space, and that's lost and found. I wish to all of you could have listened to the debate on should information only and that open-ended catch can be there. And I'm sure that can open up a lot of fun discussion. I think we probably ought to be drinking beer at the evening around a bar and having fun with that. But I would just share with you that was something that we did. I believe that we were not completely exhaustive, and we should. I'm just going to caution all of you, and I'm sure this is something that many of us already believe in. Information only is a tough one to have as a category and a classification because it's very hard to do any kind of comparables on. So with that being said, I'm going to move forward. You can see a lot of the other information in here. We were really appreciative of the industry feedback that we got to this. Many of the partners who provide some wonderful off-the-shelf programs for security incident management systems. We had a lot of feedback from those of you who took the time to respond to us. But there was something that we realized while we were in the middle of all of this that we needed to really address, and that was, well, we could give these incident categories names, but we really also needed to create definitions for them. And I would offer to you, if anybody ever says, hey, we need to write a glossary of terms and we should do that, please run. I do not encourage you to take on that effort ever again. And I say that sheepishly. It was important for us as an industry, though, to actually say, what are we using as our defined terms? And so as we go into the glossary, you'll find that there are some things that we are trying to bring forward. Many of you have probably noticed that there has been definitions in our individual guidelines for really since the inception of some of the earliest guidelines back in 2006. And, as we made the move from position statements to guidelines, we were realizing that we were always trying to be sensitive to what were the terms and how were they defined. But I think we were relying on the fact that there were certain industry terms sitting out there. So let's pop into this particular document for a second. And again, for those of you who are members listening right now, this is available online at IAHSS.org and is very well there. And what we wanted to do was start trying to create the definitions that were in our guidelines. So we curated from all the guidelines that we have crafted over the course of the inception of the process, as well as recognizing that every single thing that you just saw in the framework, we wanted to make certain that it was defined, that it had a definition. I think right now, if you were to look in here, you'll see that there's somewhere in the neighborhood of 222 current definitions. I can tell you it will grow just with the work we're doing in the council already. That is continuously trying to make certain that we have a defined understanding of how something is basically defined. I'm using the same term twice, which we always try to not do in the council, right? When we're writing guidelines. But let's just go through here. I'll just let you see a couple things. A great one. We talked about assaults earlier. So let's just look at aggravated assault versus aggravated sexual assault. There were some subcategories in the framework earlier. You can see where we have. What's interesting is people were probably like, well, why don't you just go with uniform crime reports for everything that's criminal? Because one, that's not necessarily applicable. To Dave's point earlier, we wanted to be mindful of how these definitions could stand up to the test of multiple jurisdictions. But you can see as you look at the right, an aggravated assault, but we actually looked at different places. So not all of these definitions are our own. We're trying to make certain we cite where we got them from. You'll notice that legaldictionary.net or uslegal.com for these two assault particular definitions. But you'll notice that the actual definition of an alarm was one that was much more vague. And if you ever looked at any kind of research around it, you might find it about 6 or 7 different definitions. And so what we ended up doing as a council was actually creating our own definition. So you will see that. We tried not to do that unless we felt it necessary. So in suggesting that to all of you, it was important that we took advantage. All hazard approach is a great example, as you look on the screen right now from the CMS expectations. Pretty long definition, but we thought it was appropriate, and we thought we should be inheriting that and taking that on as our own. So as you go through here, you'll notice that there are places that we show where these were defined. You take the audit trail, which actually, for those of you who are familiar with our security design guidelines for healthcare facilities, you may recall that we actually built a glossary of terms inside that booklet itself. And this is where the word audit trail came from, recognizing that that was something that was important. But if the conversation or the definition that we found didn't have healthcare specific centric nature, that's what we wanted to bring to the conversation. So as you go through here, I am not going to bore you with trying to give you 222 definitions. I'm sure you would just absolutely love if I did, tongue in cheek, right? But in saying that, I think it's important that we realize that the glossary of terms are meant to help us understand how are we defining it? What is it that we're really trying to capture? So as I go back in and think about closing up our conversation together, I think it's important that we really look at how the framework can be readily adopted into your healthcare facility. I'm going to ask all of you to say, please give that due consideration. It's a lot of work. It's going to be change. But if you've ever had the conversation with an administrator, well, how do you know that? What's the industry doing? And you can't bring data that others are doing in addition to your own. And you find yourself fighting what I refer to as a personal bias, or commonly, for those of you who've listened to me speak in the past, I refer to it often as an administrative preference. We're never going to be able to refute that if we're not coming together as an industry to really bring forward something that says, here's what we're actually collecting and here's how this information is done. And when we're all collecting information differently and their variabilities are so great, and all we really can do is do a couple things on crime, but the amount of patient assistance, amount of information that we're putting, the really heavy activities of our security staff, if they're not being collected and we're able to share, wow, why is a facility like mine? Why come the officers there are spending countless time and numbers of events, but it's different than what I'm seeing? Or you're on the other end, you're spending a significant amount of more volume doing these and your counterpart. And what we really want to do is say, how can we bring this? I may not see the full advantage of this effort in my career, but I hope for those that follow us in our footsteps, those that are really coming in behind us, that once we start getting the industry moving to a consistent approach to how we're collecting data, and that means we all have to do a little bit of something different. There's probably not one entity that's actually going to say they can adopt a framework and it be exactly as they're using it now. But I am convinced over the course of time, it will allow us to make better decisions. It'll allow us to really be able to argue for more resourcing that'll happen inside of healthcare security that makes the most sense. And it's not just a personal bias of an administrator who comes in and says, oh, I want to bring this particular defensive equipment in, or I don't want it in, or we're seeing these kind of events and they're using subjective information. It's always going to have a play, but we want to be able to follow the lead of our chosen industry of healthcare and move our industry towards evidence-based approaches. This is going to take years, but it's got to start with the first step. That's the framework. The definitions are following, just so we have definitions, so when you're asked, we know what's happening. But I just want to make certain that all of us are really understanding this is important, not only for today's environment, but for all of us for everyone that follows us. So with that being said, Dave, if you don't have any closing comments, I would say we go to question and answer and allow our colleagues to post some conversations and see what we can do to help them get more clarification than we already have.
Yeah, my only last comment is simply that you know, I don't win every battle I have with my C-suite on trying to obtain the resources and things that I need, but I do feel a lot better once I make sure that they are making an informed decision. So as you talked about, each individual site or location might have its own culture, its own administrative preferences. Well, as long as you're doing your job to make sure that the powers that be have the are informed of the information and informed of the data, that's all really you can ask for, is helping them make an informed decision, and this will help you do that. So let's turn it over to questions. If anybody has any questions, we can we'll do our best to answer them. If not, we can get back to folks.
Yep.
I'd like to remind people too, if you'd like to raise your hand in, oh, Gloria Graham has raised her hand. I'm going to go ahead and allow you to talk. So that is an option as well, in addition to typing in your question. Gloria, you're on mute. There you go.
Hi, good morning. Thank you so much for this. This is really good work, and I can tell you within our agency, we are very focused on this, and we're excited to see it come out, and we're going to be making the transition. I just have a quick question, whether there's been any thought about tying this to the IAHSS program of distinction, perhaps adopting, you know, so that we can make sure that those departments we're recognizing, that'd be one way at least to incentivize them to go ahead and adopt these standards.
Gloria, that's a wonderful idea. I wished I could tell you that we had debated it and discussed it, but I think you just populated that wonderful thought process into the key ears of our executive team and our board.
Yeah, it's a valid point. I see a question here online. Are any vendors helping with common incident names to support healthcare, report, executive, etc.? So yes, we have discussed this with a number of different data collection vendors. And I think as this evolves, you'll see that those data management companies will likely slowly start to adopt these some of these processes in the bundling of their products, because if they understand that this is, you know, for example, if there's a large audience that can benefit from them customizing an IAHSS package within, say, their offering, their service offering, I think that's going to help everybody. It'll help them and it'll help us. So we have engaged with them on some of this work, and I think as we move forward, we're going to see more and more engagement from our vendors who are supplying the data management services.
I wanted to, as you were sharing that, Dave, I was checking on a couple things in the chat. I wanted to acknowledge Jeff Young, who has been at the heart of the data warehouse project. He's taken advantage of listening here this morning. And I just wanted to make certain that I share something he shared with this group, that he's working closely, and we are very much aligned with the data warehouse project. There's been several conversations over the course of the last couple of years just to make certain that this body of work and what they're trying to do is collecting together. The same thing would be true with the Foundation Crime Survey. But what Jeff is also saying is, in the coming few months, the data warehouse team will be looking for a few early adopters of this in their instant reporting system to beta test and pilot. So if anyone is interested in being a part of that exercise, please reach out to Virginia, to Jeff, or to anyone on staff there at IAHSS, and just make certain that you're letting them know. And I think they'll be happy to have a conversation with you. Thanks, Jeff.
Okay, we currently don't have any more questions, so I'm going to ask one more time before we wrap up. If you have a question, and one just came in, can you discuss the discussion and decision made to use 5 types of workplace violence typology?
Certainly. let me see if I can't get back to that particular issue. And yeah, we have them right here on the screen, so I'll leave it there for those of you who have really good eyes. You know what, I'll pop it back up here so we can get into this. My apologies for that. So the first four, I think, are pretty traditional, right? This has been embedded in the OSHA guidance 3148 since really the mid-90s. But most of you are probably looking at type 5 and saying, I'm not quite as familiar with that one. And that's the ideological violence directed at a healthcare facility. It's people and property for ideological, religious, or political reasons. A lot of times it's extremist activity or value-driven groups who's justifying their belief. This was a topic that was brought forth, and we thought it's still relatively new, but we really believed it was important for us to start thinking about if we're going to be subject to targeted violence. And at the end of the day, we decided to go ahead and bring that forward. It was a recommendation of both Kat Kemper and Lisa Terry, and highly debated. But at the end of the day, I think we all came in unanimously of saying, let's go ahead and introduce that. I don't know, Dave, if you would want to share anything further about that.
Well, I think you've covered that. It's that whole business is a little bit different north of the border, but I think we can work it into the way we collect our data.
What we're really trying to do is get a sense of who's committing the acts. And if you really think about it, type 2 is what I commonly refer to as patient-generated violence, which is obviously the vast preponderance of what we see inside of healthcare security. And so what we're really trying to get a sense of, where's the violence stem from, is what we want to try to collect long-term.
Hey, Tony and Jeff, Dave, this is Kat. I think this plays is very timely, especially with the Roe v. Wade reversal. I think we've started seeing, especially some of the physician offices, being targets of these types of type 5 violence. And so again, I think this was a way for us to capture similar events like that.
Yeah, that's a really good example of what the type 5 violence would illustrate. That's a really good example.
Absolutely.
All right, I'm just looking to see if there's any more questions that have surfaced here. Heather, is there any more questions that you're aware of?
No, I don't see any questions. I don't see any hands up. So I feel that if you think of something after this webinar has ended, feel free to reach out to Tony, Dave, Kat, anyone on the Council of Guidelines headquarters office. We'll be more than happy to answer it. I'd like to thank Tony and Dave for taking the time to present this information today, and for all of you for joining us. So that concludes our webinar for today. Thank you.
Thanks, everyone.
Thank you all.